Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
I want to welcome those in the room as well as those online to Redefining the Patient Journey, the Promise and Practice of NTRK Fusion-Positive Cancers. I'm Ted Leitch, a pediatric oncologist at the Children's Hospital of Philadelphia and University of Pennsylvania, and lead our rare tumor program as well as our developmental therapeutics program. I'm excited to be joined today by Dr. Nicole Cipriani, Herbert Long, and Jonathan Trent. I'll let them introduce themselves. Dr. Cipriani.
Thank you so much. Hi, everyone. I'm Nicole Cipriani, from right here in Chicago at the University of Chicago. My subspecialty focus is in head and neck as well as bone and soft tissue pathology. Looking forward to talking with you all tonight.
Sure. Hi, I'm Dr. Herbert Leung. I'm a medical oncologist based at the Chinese University of Hong Kong. My interests are in sarcoma, lung cancer, as well as early phase drug development. And it's a pleasure for me to be here. Thank you.
Yeah, I'm John Trent. I'm a professor of medicine at Sylvester Comprehensive Cancer Center in Miami, and I lead the sarcoma group.
Welcome all. Thank you for joining us. Here's the agenda for tonight. I'll start with a brief introduction, and then Dr. Cipriani will talk about testing for NTRK fusions. Dr. Long and Dr. Trent will talk about evolving standards, clinical updates on NTRK fusion-positive cancers, primarily focusing on adult patients. I will talk about the pediatric and adolescent experience with TRK inhibitors, and then we'll have some time for a Q&A at the end. So just briefly to level set, for those who are not familiar, there are 3 TRK receptors that mediate neurotrophin signaling. In normal cells, these function as receptor tyrosine kinases that signal downstream of these growth factors that promote sympathetic nervous system development, primarily in utero. These receptors also have roles in postnatal life, including sensation of pain, regulation of appetite, and proprioception. When the TRK receptors are stimulated by one of the neurotrophins, they signal downstream through the ERK-MAP kinase and AKT-mTOR pathway to promote cell growth and survival. And these are the pathways that are co-opted in cancers that have NTRK gene fusions. In cancers, the NTRK signaling pathway can be co-opted through the presence of a fusion in which an unrelated fusion partner is joined to the TRK kinase that promotes ligand-independent activation and constitutive expression of this kinase, driving cell signaling and therefore oncogenesis. TRK fusions are similar to BCR-ABL fusions in leukemia, but unique in that they occur with a wide variety of different fusion partners, with dozens of fusion partners described across a range of many cancers. In general, TRK fusions are considered activating if they are in frame and retain the kinase domain, even if they're novel, because approximately 1/4 to 1/3 of patients may have a novel NTRK gene fusion that may not have been described previously. NTRK gene fusions are found across a diverse range of different cancers in both adult and pediatric patients. In some very rare cancers like secretory breast cancer, infantile fibrosarcoma, and congenital mesoblastic nephroma, these are nearly universal drivers within those cancers. But in more common cancers like lung cancer, sarcoma, as well as colorectal cancer, NTRK gene fusions happen at a lower frequency, here reported as less than 5%, and in many cases less than 1% of these cancers will have an NTRK gene fusion. The reason we're talking about NTRK gene fusions tonight is because multiple drugs have shown histology-agnostic activity across the range of solid tumors that have these fusions. Larotrectinib and entrectinib are first-generation inhibitors, and you can see here their waterfall plots demonstrating histology-agnostic, really remarkable activity. And repotrectinib is a second-generation inhibitor that has also shown histology-agnostic activity. You'll hear more about the data for these inhibitors later tonight. Given the diverse histologies in which NTRK fusions occur, it's important that we think about how do we identify these patients. And there have been a number of different testing algorithms published. Here's one I'm showing from ESMO, but Dr. Cipriani will cover these in more detail in her talk. So with that introduction, I'd like to introduce Dr. Cipriani to talk about testing for NTRK fusion cancers.
Thank you very much. All right. Before we get into the pathology component, there are a couple of polling questions. So for those of you who have your devices out, we're going to ask first, at what stage do you typically request comprehensive genomic profiling to test for NTRK fusions? At initial diagnosis, after first-line treatment fails, after all standard treatment fails, rarely or never, meaning you never rely on comprehensive genomic profiling, you sometimes rely on single gene testing, or only for specific tumor types known to have quite high fusion rates. Excellent. So half of people said at initial diagnosis, followed by only for specific tumor types known to have high fusion rates, or after first-line treatment fails. And then lowest rates were after all treatments fail, and then rarely or never. So quite a few of you are kind of doing this up front. I don't know if you as clinical treating physicians have comments on when you would do the testing?
In the sarcoma space, we generally do comprehensive genomic profiling at diagnosis.
Okay, so in line with most of the...
Yeah.
And I guess, I mean, in the lung cancer space, aside from NTRK fusions, there are so many actionable alterations nowadays that I think the trend really is also to do upfront NGS testing.
Okay, great.
And we do the same in the pediatric oncology space, also generally upfront testing for all of our patients.
Excellent. Yeah. Similarly, at University of Chicago, most of our testing is done right up front with next-gen sequencing. All right. And the second question, what is the primary barrier to routine NTRK fusion testing in your practice? Poor or insufficient tissue sample, long NGS turnaround times, which we'll get into later, lack of access to advanced labs, high cost or lack of reimbursement, confusion over testing algorithms, or difficulty interpreting complex NGS reports. Okay, so answers are kind of split in the top thirds between poor or insufficient tissue sample, lack of access to advanced labs, high cost, i.e., and lack of reimbursement. Lower were answered long NGS turnaround times, confusion over algorithms, and difficulty interpreting reports. So mostly sample issues, laboratory access, and sort of insurance or government reimbursabilities. Does this jive with your experience?
Yeah, and I think some of the lack of access may have to do with international participants too. That's something that we see in the sarcoma medical world.
Understood.
I think in the pediatric oncology space, I agree. In the United States, there's actually free testing for many pediatric cancer patients through the Children's Oncology Group that's offered with clinical return of results. So it's really not a barrier here, but I agree that internationally it is a significant barrier for many patients.
I think for lung cancer, I agree with the audience and the participants. I think typically it's insufficient tissue sample. Certainly there are other ways of doing NGS now with, say, liquid biopsy, but unfortunately, a detection of NTRK is not very good with that sort of modality, and we really need to have tissue for this analysis.
Understood. And what I will take away from this as a practicing pathologist, what can I do, right, to make sure that the tissue is treated appropriately? Sometimes it's very small things. Sometimes it's cytology. Sometimes it's core biopsy. And so we have mechanisms to sort of spread the tissue out over different cassettes, over different sources, or make sure that tissue is not inappropriately decalcified. Right? For example, if it's a bone specimen, we would prefer to use something like an EDTA decalcifier rather than a hydrochloric acid decalcifier to maintain appropriateness for DNA sequencing, or RNA sequencing for that matter. So definitely a lesson for us in the lab as well. Okay. So as a reminder, right, the NTRK gene, neurotrophic tropomyosin receptor kinase, tyrosine kinase, does encode, right, this family of transmembrane receptor tyrosine kinases that, as you heard, play an important role mostly in the development of the nervous system. They are expressed in embryonic as well as adult, central and peripheral nervous system. And interestingly, the first TRK fusion protein was found in 1982 in a colorectal adenocarcinoma cell line. And the three genes, right, are NTRK1, NTRK2, and NTRK3 on chromosomes 1, 9, and 15. And the proteins are not the numbers, but the letters, TRK A, TRK B, and TRK C. As you can see on the screen, there is an extracellular ligand binding domain. There's a transmembrane domain, and of course, an intracellular kinase domain. And normal, functionally, right, the ligand binding encourages the receptors to dimerize, which induces autophosphorylation of that intracellular tyrosine kinase domain and activation of those downstream signaling pathways, including the MAP kinase, PI3 kinase, and PKC pathways, which, as you heard, help promote cell growth, cell differentiation, and cell survival. The most common mechanism, of course, of TRK alteration is gene fusion, with the specific most common fusion being ETV6, partnered up with NTRK3. ETV6 is a transcription factor, often normally expressed in hematopoietic types of cells. In this case, it's ETV6 NTRK3. NTRK1 and 3 fusions are thought to be more common than NTRK2. However, they are all implicated in various diseases and are specifically targetable by the TRK inhibitors. However, the NTRK genes can also be altered by things like point mutations, gene amplifications, messenger RNA overexpression, which can occur in approximately 14-15% of other TRK non-rearranged tumors, right? Unfortunately, these alterations are generally not targetable by the inhibitors. Once the inhibitors are administered, which you'll hear a lot about later, the gene, right, can develop resistance mutations. And so usually these are point mutations in that intracellular tyrosine kinase domain that can come, following treatment with those first generation inhibitors and sort of abrogate the effect of the drug. The most common fusion partners with 1, with 2, and with 3 are listed there. We're not necessarily going to go over those in detail. The specific chromosomal changes that you may encounter that lead to a gene fusion are the 3 listed on the left. So you can have, this is just in general, right, for all fusions and translocations of genes. You can have a deletion or an inversion of genetic material on the same chromosome, right, which put 2 genes together. You can have tandem duplication and between 2 homologous chromosomes, where additional copies are placed on one chromosome. Most commonly, however, what we're dealing with is translocations between 2 different chromosomes. Most of the NTRK fusions are in this category, where the material is swapped because the long or the short arms are swapped. Lastly, kind of up at the top, is alternate splicing of messenger RNAs, which has nothing to do with the DNA itself, right? But it's post-transcriptional modification of those messenger RNAs, which is possible but less common in these cases. Mostly what we see are the 3' portion of the NTRK gene fused with the 5' portion of whatever the partner is. Remember, ETV6 being the most common. In these cases, the tyrosine kinase domain from the NTRK C terminus is retained, which is the important functional domain. And then that domain becomes activated, right, by that partner gene to drive uncontrolled cell proliferation. What the partner gene does, the 5' portion, is it sort of provides this dimerization that does not require the ligand, right? Does not require the extracellular ligand, so these dimerize independent of ligand and cause this constitutive downstream signaling. The chimeric protein, again, as we already heard, drives through the intracellular pathways. In a little bit more detail, I wanted to mention the specific types of tumors that we see. And so highlighted in sort of red are those that are hot, right? Those that are greater than 90%, almost disease-defining NTRK fusions. Those being secretory carcinomas of all anatomic sites. So the most common anatomic sites we see secretory carcinoma are the salivary glands, as well as breast, especially in the pediatric population. Infantile fibrosarcoma, very characteristically, ETV6 NTRK. And then the variants of congenital mesoblastic nephroma. Emerging, right, both in adult and pediatric populations are thyroid cancers with NTRK fusions, so second most common, as well as some gastrointestinal stromal tumors. And then as you can see, the lower ones are things like lung, various sarcomas, gliomas, etc. And so we'll talk about histology-based triage in a minute. What I'm looking for, right, for NTRK fusion, when I see the morphology of these tumors, is characteristically, right, secretory carcinoma on the left, again, as I said, within salivary, within breast. This can even occur within thyroid. This can occur within skin. This can occur within other visceral organs like the GYN tract, et cetera. So it's all over the body, just most common in salivary and breast. It's defined by these microcystic spaces and specifically strongly S100 and mammoglobin positive, right? So my H&E morphology and my immunostaining can direct me to that diagnosis. Infantile fibrosarcoma is this very cellular fasciculated neoplasm that occurs mostly on the extremities and overwhelmingly within the first couple of years of life. Similarly, cellular mesoblastic nephroma, again, kind of a spindle to round cell tumor occurring on the kidney, again, before age 3. And then some papillary thyroid carcinomas that are negative, right, for the other common drivers of papillary carcinoma or follicular carcinoma for that matter, like BRAF or RAS, right? So these are the conventional thyroid driver negative tumors. We might start to think about an NTRK fusion. And so here comes the sort of histology-based triaging, where I make a diagnosis, or my fellow pathologist, right, of a tumor that has a very high frequency of NTRK fusion. Whether it be me that's triggering the test or the clinical team that's triggering the test, many of these cases will get tested up front, whether it be by FISH, by immunohistochemistry, or by direct to next-gen sequencing. Depending on the expected frequency of mutation in these tumor types, if your FISH or your IHC are negative, you may end up refluxing, to NGS anyway. So most cases end up having sequencing regardless of sort of the triage tests. How about tumors that have a low frequency of NTRK fusion? Maybe you've already performed routine next-gen sequencing, for example, for all of the lung cancers or the colon cancers, right, or some of the thyroids, and you found none of the common drivers, right? In that case, we might reflex to either an immunohistochemistry or straight to next-generation sequencing. There are a couple of different algorithms that have come out of Memorial Sloan Kettering. The histology-based triage is essentially similar to what we've just talked about. And they have also offered a genomic-based triage, again, mostly for those tumors that get upfront testing. And if they are negative for the common drivers, then you will have screening for NTRK fusion. And so the ways, right, that we can test are listed on this chart here. Easiest, fastest, but maybe the least specific and sensitive is going to be immunohistochemistry, right? So this is any of the genes, 1, 2, or 3 that are fused. As you can see there, the sensitivity varies depending on which gene is affected, and the specificity is usually quite high, right? So if it's positive, we can rule in the fusion, but if it's negative or weak, we may reflex. This is probably the cheapest and probably the fastest, but again, might require confirmation. Then we have FISH. So if we want to test all 3 genes, we'll need to do 3 tests, right? So unlike the IHC, which covers them all, FISH needs to be separate for 1, for 2, and for 3. And if the usual breakpoints are there, it can be very, very sensitive and specific, as well as relatively inexpensive compared to some of our molecular testing. Right, so then we move into PCR. which requires a small amount, 1 microgram of RNA, takes maybe about a week, quite good sensitivity and specificity. However, many institutions now, right, are doing either DNA and or RNA-based sequencing. RNA-based sequencing will be quite sensitive and specific, requires about 200 nanograms of RNA. And if you're doing pan sequencing, can find other genes that might be fused, not just NTRK, right? Similarly with DNA, this is mostly a pan sequencing, but is arguably the longest, right? So DNA next-gen sequencing is the longest, and may have some difficulty in finding the fusions depending on the exact rearrangement. RNA-based testing might be a little bit better. And then in the end, sort of hybrid, where you essentially do both. We at the University of Chicago have both a DNA and an RNA NGS panel. That's kind of what we end up reflexing to for most of our cases that require sequencing. So in the end, for pathology, right, NTRK fusions are common in rare tumors and rare in common tumors, but we mostly look for the specific tumor morphologies, the specific diagnoses that raise suspicion for fusion. Not all patients, of course, may require immediate treatment with TRK inhibitors. However, as we saw earlier in the polls, many people are doing testing, including all of us, at the time of diagnosis to sort of get the ball rolling, right, for future therapy, versus to only test when therapy is warranted, and then you may prolong treatment when it's actually needed. All of this, right, requires discussion between pathologists, between clinical teams, which we all have each other on cell phones, on pagers, and our weekly tumor boards, and really critical communication for what is expected in the clinical care syndrome. So.
Perfect. Great, thank you very much, Dr. Cipriani. Next, we're going to move on to Dr. Long and Dr. Trent, presenting some clinical data on NTRK fusion-positive cancers. But first, we have a patient video of a patient who has an NTRK fusion cancer to share with you.
They sent me after doing the surgery. They sent me home and told me to wait, and then I would get a biopsy. Eventually, I got a biopsy, and they, took it back to do tests on it to try to see if the mass was cancerous or not, and was still waiting to get that result for a while. Eventually, they called me to say yes, it was cancerous, but they still need to do more tests to see what type of tumor it was, and to see what treatments would be available for me. And that was still a waiting period as well afterwards. I felt very anxious because someone tells you have a mass and they don't know what to do. As a doctor telling you this and they don't have any answers for you at that point, it still feels very anxiety producing, and the fact that they couldn't give me an answer at that point was scary. Well, the doctor told me, they said it was an NTRK3 fusion, and they said that there was this drug that it was a NTRK inhibitor, and that would specifically target the tumor itself, the specific tumor, and they put me on that. My parents are very involved, and they did more research about it too. I think for me, honestly, though, I was just more focused on, here's this drug we know is going to work, take it, and I didn't really ask questions because I was just, at that point, wanted to just get on something. And they said it was going to work, so I was like, okay, well, I'll do that then. That was, saying that, they had an idea of the medicine, they knew what medicine to take, they knew exactly what was wrong, that was very reassuring. And it was very reassuring that they had that available and that they could get me on it super quickly, and that, that it wasn't, I didn't have to wait much longer. They could just, my insurance approved it, and then I was on the drug, and that was that. The treatment's been fine. When I first started taking it, the main side effect I felt was just fatigue. And I still do feel that, especially, I've been on it for, 3 years now or so. It's like when I first take it in the morning, I get tired. I take it twice a day. But it hasn't inhibited me from doing the things I like to do, which is really nice. Yeah, no, I did think I was gonna have to go on chemo, and lose my hair and you know, deal with the nausea and everything that, you know, that comes with chemotherapy. But so I was very grateful that I didn't have to go through that. I'm really grateful that they had this specific medicine that, and it allows me to just, you know, live my life and not, and it's kind of just taking like an Advil every day, honestly. I got surgery. I mean, they gave me this medicine and it shrunk the tumor. And so then they were able to take out most of it. They still had positive margins because I couldn't get it out all the way. So I'm still on the medication to try to just make sure it doesn't come back. I feel like because I don't look like a stereotypical cancer patient, I feel like they didn't take me seriously sometimes, or I just felt like I wasn't, like, my voice wasn't really being heard. And not that they didn't care, but it just felt very much more like okay, like here's this drug where you're on this drug, you have fatigue, okay, like kind of deal with it. Even though it's not awful. Like I'm fine. Like the fatigue's not awful, but it's still just like I'm always like a little bit like nervous about the what ifs. And I feel like as of now, they're just kind of kicking the can down the road to see like, okay, let's make sure it doesn't come back, but we don't know what's in the future. And I know they don't know, so obviously they can't tell me, but there's still that uncertainty that's not fun. Yeah. I guess that's the one thing is I would want clinicians to know just like, I don't know, have a little bit more like patience with people that are anxious.
Thank you very much. I think we're going to have Dr. Trent and Dr. Long take us through a couple of polling questions.
Sure, thank you very much. I think before we go into the actual sections of both lung cancer and sarcoma, we do have one or two polling questions for all of us, and let's go through these. First question is, what is your typical clinical pathway for patients with NTRK fusion positive cancers? Is it A, treat locally with TRK inhibitors, B, consult external KOLs before treating locally, C, refer to a specialized center of excellence, D, prioritize clinical trial enrollment, or E, unsure, and we currently lack an established protocol. Okay, I think the results have come in. I think it's quite an interesting spread of results, quite fairly spread as well. It seems as though treat locally with TRK inhibitors at your local institution or referral to a specialized center of excellence is the most common choice. Followed by a consultation with external KOLs before treating locally. Clinical trials certainly are very important, and I think that's the next option. And right now, also, we have some respondents where they're actually unsure of an established protocol, and certainly I think that's one of the reasons why we're having today's forum. Are these results sort of similar to what you would see in your practice?
Yeah, I think this is very reasonable. The only comment I might add is that for rare tumors, rare molecular conditions, we should always prioritize clinical trials when they're available.
And from a pediatric point of view, is it any different as opposed to how we should be doing this as opposed to adults?
No, I agree completely with the comment around clinical trial enrollment. Certainly that's even more priority, more commonly done in pediatric space. But no, I think absolutely treatment with a TRK inhibitor, either with or without consultation, is very reasonable.
Okay, all right. I believe a second question, which Dr. Trent will go over with us.
Thank you. Yeah, so our second question is, how do you primarily select among the approved TRK inhibitors for NTRK fusion positive cancers? A, use first gen up front, save next gen for resistance. B, based on central nervous system penetration and brain metastasis risk. C, based on the side effect profile and patient comorbidities. D, uncertain about the differences and how to sequence them. Or E, I have no experience using TRK inhibitors, which is perfectly fine. This is a rare condition. The answer is use first gen up front, save next gen for resistance is the most common answer. The next most the most common answer is I have no experience using TRK inhibitors, which you may say I have no experience doing polls. But anyway, the last answer, I have no experience using TRK inhibitors, is the most common answer, which is very reasonable, this being a very rare condition. Second most common answer is use first gen upfront, save next gen for resistance. And third most common, based on central nervous system penetration and brain metastasis, with the other answers that you can see. So, do you think these are reasonable answers, Dr. Lung?
Yeah, I think they're all perfectly reasonable. To
Yeah.
be honest, there's no real right or wrong answer to this. And certainly, I'll be going through some of the data, which hopefully will be able to shape the practice of how we should be sequencing some of these agents.
Yeah, any comments from pediatrics?
Yeah, no, I agree. These are very reasonable answers, and it's very understandable that most people have, which the highest answer is that people don't have experience. I will say that in the pediatric space, we'll go through the data, but the first generation inhibitors are the only drugs that are approved for people less than 12. And so certainly if you're not on a clinical trial, that would be my practice.
Yeah. Okay, so we'll move forward with the next presentation, and I'd like to turn over the podium to Dr. Long.
Thank you very much, Dr. Trent. So I've been tasked to talk about the updates in terms of treatment for non-small cell lung cancer with NTRK fusions. And you've seen this diagram already from our previous presentations, really just to highlight to you the fact that in adults, non-small cell lung cancer, the chance of having NTRK fusions is actually relatively low. But having said that, we know, of course, there's a high incidence of lung cancer. It's a common cancer. So if you think about the actual patient numbers, it's actually not as low as you think. So therefore, in actual fact, in non-small cell lung cancer, this is a condition with NTRK fusion where there have been studies and there have been various outputs as well as clinical trials showing its efficacy. Now, this is a pie chart that you may have seen many a times at various meetings talking about the various driver alterations in non-small cell lung cancer. And certainly, you're definitely aware and familiar with the common drivers such as EGFR, ALK, and ROS1. NTRK rearrangement is a fusion, which is actually relatively rare, accounting for about 0.23% of all non-small cell lung cancers. And I think, although this is, again, a small number, it's very important for us to be doing testing in terms of upfront NGS testing for our patients, not only just to identify the rare NTRK fusion, but you could see the number of actionable alterations that's actually available in our treatment armamentarium now for patients with non-small cell lung cancer. Now, just walk through some of the clinical data of the various NTRK inhibitors that actually Dr. Leach have already mentioned in the introductory slides. And at first, I just want to walk through the data for larotrectinib, which is a first-generation NTRK inhibitor. And these are data results specific to patients who have lung cancer in the clinical trials. So what you can see here is the waterfall plot showing the responses of NTRK fusion positive patients who were treated with larotrectinib in the various trials that was then combined for this particular analysis. And what's always interesting to note is in many of these slides and many of these presentations, there's always a mention of whether or not there is CNS metastasis at baseline, because of course, brain metastasis is something that's very important in patients with NTRK fusion lung cancer, and an effective NTRK inhibitor must have good brain penetration. What you can see here, certainly with the waterfall plot, is a lot of patients do benefit from the use of larotrectinib in this situation. The overall objective response rate in all patients is 69%, and specifically for patients with CNS metastasis, very similar at 67%. Most of these patients actually generate a response in terms of partial response, some with stable disease, and very, very rarely are patients having primary resistance to NTRK inhibitors. Now, this is a swimmer's plot, anti-gravity swimmer's plot, where patients are swimming upwards. But what you can see certainly, and what I'm really trying to bring home here, are the fact that for some of these patients who are actually benefiting from treatment, they're benefiting for a very long period of time. Just to focus on the y-axis, we're looking at months of 72, so that's 6+ years of treatment, and these patients are still ongoing. Now, looking at some of the more concrete data of, say, duration of response, progression-free survival, and overall survival for patients who are treated with larotrectinib, what you can see here are these three Kaplan-Meier curves, really indicating the fact that patients are able to benefit for a long period of time. The median duration of response is 34 months, and you can see at the time of analysis, the upper bound of the 95% confidence interval has actually not been reached. Progression-free survival has been documented at 22 months and overall survival of 41 months. Now, in terms of the adverse events, in terms of safety profile, actually the first generation NTRK inhibitors, this one is an example of larotrectinib, and I'll talk about entrectinib a little later on. It's actually quite similar. What you can see are some changes in terms of transaminitis of ALT and AST, as well as some weight gain, and also some other low-grade toxicities. I think what's very important to note is the fact that although there are these particular adverse events, most of these are of grade 1 or 2, and very minimally are they of grade 3 or above. Now, moving on to the other first-generation TRK inhibitor, and that's entrectinib. Again, this is an amalgamation of all the clinical trials, of which there were lung cancer patients, and putting all these patients together for this particular analysis. You can see actually a very similar waterfall plot where, again, there is a very good objective response rate of 63% for the entire patient population. Also for patients specifically with CNS metastasis, 60%, and those without CNS metastasis, 64.5%. Again, most of the patients are benefiting with at least a partial response or stable disease, of course, and very minimally, a very small number of patients have primary resistance. This is a swimmers plot where they're swimming in the appropriate direction, and you can see, again, I appreciate the fact that these are very small prints, but there are all these arrows at the end indicating, of course, the fact that patients are continuing on treatment, again, for a long period of time. And if we want to look specifically at, again, the more specific endpoints, this is a Kaplan-Meier curve showing the duration of response. What you can see here on the table, again, is for all the patients, which is 51 patients in this collection, then subsequently divided into those with CNS metastasis at baseline or no CNS metastasis. And certainly you can also see the fact that there is a very good progression-free survival of 28 months in terms of median progression-free survival for the entire population. And then likewise, very similarly, whether or not you have CNS metastasis, you still manage to derive a very similar benefit. And likewise also for overall survival as well. And the 12-month event-free survival rate is somewhere in the range of about 70 to 80+%. Now, with entrectinib, there have been a bit more focus on intracranial efficacy, and certainly this is a snapshot of the 14 CNS evaluable patients for efficacy in terms of results. And what they found was that the intracranial objective response rate is about 64.3%, where in actual fact, 7 patients, which is half of the patients, 50%, actually had a complete intracranial response. Some of the patients, of course, also benefited with partial response or stable disease. The duration of response have been very good as well for patients with measurable CNS metastasis, with an intracranial duration of response of northwards of 55.7 months. Now, this is another representation, again, of the toxicity profile, and really just to highlight to you the fact that most of these side effects are really in the grade 1 or grade 2 category, again, with transaminitis, as well as weight gain. Interestingly, in actual fact, for weight gain, this is a common toxicity amongst this class of agents because of the TRK inhibition, and there have been some documented grade 3 weight gains in some of these patients. Now, this is just a summary of a side-to-side comparison of larotrectinib and entrectinib in patients with TRK fusion lung cancer. It's very important for us to note that this is not a head-to-head comparison per se, but really just putting the two results together for sort of a visual representation. And again, really just to highlight the fact that both of these first-generation agents do come with very good objective response rates, progression-free survival, as well as overall survival. Now, moving on to second-generation TRK inhibitors, and repotrectinib is actually a second-generation TRK inhibitor, and there have been some recent results published from the Trident study, which was actually presented previously at conferences and also recently published by Dr. Benjamin Bess on behalf of his colleagues. You can see here, again, this is a big collection of patients, and specifically the ones which are highlighted, I think, in orange color are the ones with non-small cell lung cancer. And certainly you can see the good duration of response for patients who are actually treatment naive. So a second generation TRK inhibitor used in the first line setting. The objective response rate is documented here at about 60%. Now, this is actually a representation of patients who've had prior TRK inhibitors. So these are pre-treated patients. And again, it is the orange bars who are patients with non-small cell lung cancer, where you can see, again, that most of these patients are able to derive benefit. The objective response rate is about 48%, and the Kaplan-Meier curve is also shown here on the right-hand side. And specifically for the patients who actually develop develop resistance to TRK inhibitors through the presence of a solvent front mutation, in actual fact, what you can see in this selection of patients, again, the orange being the non-small cell lung cancer patients, you can see most of these patients, again, do benefit from this use of second generation TRK inhibitors after progression on the first generation. In terms of safety profile, this is an analysis of the safety profile of repotrectinib in all the patients that's actually included in the trial. So not only lung cancer, but for all histologies. And again, what you can see are some of the class effect toxicities that's seen amongst the population. Certainly, there may be a little bit more TRK-specific toxicities because of the fact that this is a more potent NTRK inhibitor. But I mean, overall, in actual fact, it is quite well tolerated. And this is just a real summary in terms of looking at the various side effect profiles or various side effects that's been reported in the clinical trials of larotrectinib, entrectinib, as well as repotrectinib. And this is probably a very good reference for you to take home so that there's a clear indication of each of these potential adverse events and what is the incidence of the grades in terms of all grades as well as severe grades. Now, with all these potential treatment options that's available, it is important for us to consider how best to sequence our treatment or what is the best potential treatment approach for patients with NTRK positive non-small cell lung cancer. I think to begin with, we certainly have three very potent inhibitors, both first generation with entrectinib and larotrectinib, as well as second generation repotrectinib. There is clear data that using a second generation in the first line setting is also efficacious. So all these three potential options are feasible. Now, at the time of resistance, I think our approach should be very similar to how we would treat other non-small cell lung cancers with driver mutations, where at first we might want to decide whether or not this resistance is of oligo progression or solitary progression, where you can potentially address this particular issue with local regional therapy, and then to consider the continuation of the particular tyrosine kinase inhibitor. However, at the same time, if you're able to document potential on-target resistance through, say, another next-generation sequencing, based on the various alterations, you may want to consider repotrectinib if it was not used previously, because it is able to cover the solvent front mutation in a much better fashion. Or actually, as we're doing more and more NGS, we are seeing potentially some of the off-target resistance, such as KRAS mutation, MET amplification, BRAF mutation, as well as IGF-1R activation, as some of the examples of potential resistant mechanisms. Now, the standard of care treatment in terms of, say, chemotherapy or other treatments for that particular histology is something that can be considered, or maybe even an off-label use, the potential combination of various other types of inhibitors guided by the potential mechanism of resistance. And just to highlight what we have right now in the NCCN guideline, what you can see here is certainly for patients with NTRK gene fusions, if this was already identified prior to the start of systemic therapy, the preferred treatment approach is to use a TRK inhibitor, and it could be entrectinib, larotrectinib, or repotrectinib. In rare circumstances, you might want to start off with systemic therapy for that particular disease first, but the preferred option is to use a TRK inhibitor. At the time of progression, if repotrectinib was not used previously, then you can consider using that at that particular juncture. Now, interestingly enough, for patients who actually have been started on treatment and then subsequently found to have NTRK fusion, the recommendation actually is to interrupt the current treatment as well, and then to start one of the TRK inhibitors, and then only upon the time of progression will you consider systemic therapy. So with that, I would like to pass it over to Dr. Trent, who will be talking about the use of NTRK inhibitors in sarcomas.
Thank you. That was a lot of really dense, good data in lung cancer. What you're going to find in sarcoma is that we don't really have sarcoma-specific clinical trials. So we have to borrow a lot from the experience in lung cancer and other solid tumors. But I will say that from our experience and what's been published, that the adverse event profile is very similar between sarcomas and lung cancer. And it turns out the efficacy is also fairly similar, but we'll discuss some of that in the upcoming slides. And I'd like to just begin by introducing the concept that sarcoma is actually the first cancer known to occur in humans. This is a skeleton, fossilized skeleton that was found in the Saharan desert in the early 20-teens, and this represents an osteosarcoma. If you look at an X-ray, it will look very similar, showing this pattern of bone formation. And so we know this is an osteosarcoma. Sarcoma is also different in terms of its, not just that it's the oldest cancer known to man, but also that it is different than the carcinomas as far back as embryology. So in the gastrulus stage, where you've got the endoderm, epiderm, and mesoderm, the tissues that form sarcoma arise from the mesoderm or the mesenchymal tissues, hence sometimes called mesenchymal tumors. And these mesenchymal tissues give rise to muscle, bone, cartilage, nerve, and these are the tissues that sarcomas may arise in. In addition to being different at a embryologic, developmental, biological way, sarcomas are also very molecular. When you talk about soft tissue sarcoma and bone tumors, there's over 175 different types. So even though it's rare, and there's only maybe around 5,000 bone or 15 to 20,000 bone or soft tissue sarcomas diagnosed each year in the United States, that's spread among 175 different types. Many of those types are driven by molecular events, and sometimes it can be just one single solitary event that turns that normal cell into a cancer cell. And this may take the form of point mutations in gastrointestinal stromal tumor, KIT PDGFR, or we may see gene amplification, like in dedifferentiated liposarcoma, where we have MDM2 and CDK4 activation. As you heard earlier today, maybe in the plenary session, some of these liposarcomas can have some sensitivity to CDK4 inhibition. Gene deletion we might see in osteosarcoma. We do, however, see translocations in a number of different sarcoma types. Many of these are transcription factors and difficult to target, but some of these are tyrosine kinases, such as NTRK we see in gastrointestinal stromal tumor and fibrosarcoma. Other types you can see on this slide, and interestingly enough, protein overexpression sometimes is sufficient to contribute in a meaningful way to the tumor phenotype, such as in desmoid tumor and uterine leiomyosarcoma. The pathology is the first foundational step in the management of a patient with a bone or soft tissue sarcoma. And on this table, you can see some data where a sarcoma that was diagnosed at a community hospital was referred to a sarcoma center, for instance, to Dr. Cipriani or one of her colleagues. And what this data found was that there is a major diagnostic change in the patient's tumor type, anywhere from 19 to 25% of the time. And when we say major discrepancy,
that means a change in chemotherapy. That means you were diagnosed with cancer, and in fact, you don't have cancer. Or they were told they didn't have cancer, and in fact, they did have a sarcoma. And so, it's really critical to have Dr. Cipriani or another sarcoma expert review the diagnosis, because us as medical oncologists, we rely on the pathologist so that we understand what type of sarcoma we're dealing with. Because of those 175 different types, most of them are treated with some nuances and differences in their therapy. Not just chemotherapy, but surgical approaches, radiation approaches, et cetera. So this is a foundational step in diagnosis. Often our pathologists will also want us to add next generation sequencing or other molecular tests, not only to help with the diagnosis, but also to help us with therapeutic management. So that leads into precision oncology, and sarcoma is really a solid tumor example where precision oncology has made a huge impact on patients' lives. And for one of the biggest examples of this is gastrointestinal stromal tumor. It's the most common GI sarcoma. It has a high frequency of metastases. In fact, if you look at patients with a primary GIST that's resected, there's about a 50% chance it's going to come back as metastatic disease or a local recurrence or both. It's also a sarcoma where the gene mutation, the genotype, determines the phenotype and also determines the therapy for our patients. Now, why is precision oncology important? Well, if you go back prior to targeted therapy, the median overall survival for a GIST patient was 9 months. From diagnosis to death on median was 9 months. And in fact, some of the studies we did in GIST pre-TKI, the median progression-free survival was 1.5 months. So that's pretty much the first time you look, most of the patients are progressing. And so it really was a dismal disease with poor outcomes pre-TKI, and that's why precision oncology is critical for GIST and other sarcomas. Now, when we talk about GIST, we used to just talk about GI stromal tumor. Now we know that there are a number of different molecular subtypes within GIST. And so this is another area where NGS is critical. The pathologists help us make the diagnosis of GIST, but we also need to know the molecular phenotype, the molecular genotype, so that we can have some prognostic conversations, predictive, and treatment. And so the most common site of mutation is KIT exon 11 within GIST, and these patients we treat with imatinib 400 milligrams. KIT exon 9 patients benefit from a higher dose. PDGFR D842V mutant GIST is resistant to all known TKIs except avapritinib. SDH deficient GIST, we are now treating with VEGF receptor inhibitors. A small trial from that we participated in, a 4-institution trial. We found temozolomide had some activity, and also regorafenib, a FGFR inhibitor, has some activity. RAF mutant GIST responds to RAF inhibitors, and NF1 we can treat with MEK inhibitors. And interestingly, TRK fusion has emerged as one of the driver mutations in GIST. And these are the common driver mutations that we see. And I'd like to just emphasize that these are mutually exclusive. So patients are not going to have multiple of these pathways activated. We do also see resistance mutations in KIT that are also therapeutically important. So to learn more about these TKIs, these NTRK TKIs, a group of us participated in this study on TRK in order to really look at the NTRK gene fusions as oncogenic drivers in pediatric and adult sarcomas, in order also to learn some differences between the CNS and non-CNS tumors. And among the tumor types with NTRK, there was an interest in understanding the prevalence rates, especially in the rare cancer. Larotrectinib, of course, is the first TRK inhibitor we used, but have since experienced with entrectinib as well as repotrectinib. Although in the sarcoma space, there have not been specific studies with these agents, we borrow on the larger solid tumor studies. And OnTrek really is a deep dive into a better understanding on how these larotrectinib, how these TRK inhibitors impact sarcoma and other solid tumor patients. And so this is an AE chart with TRK fusion cancer, similar to what we've seen with the prior presentation by Dr. Long. No big surprises there. In the TRK fusion cancers, from our data on the OnTrek study, some real-world data, really it's in alignment with what's been published in terms of a median progression-free survival in the CNS of 4 months and in the non-primary CNS tumors of about 20 months. And the overall survival, of course, is not been reached in the non-primary CNS tumors, although CNS tumors have a slightly lower median overall survival. So entrectinib is active in a variety of solid tumors. This is a solid tumor study. Like I said, we don't really have GIST or sarcoma-specific survival curves, so we borrow from the larger population. And you can see that repotrectinib in the waterfall plot is incredibly active. The vast majority of patients have really met the criteria for a partial response or better. And so these patients do really well on repotrectinib as well as the other TRK inhibitors. So with that background, I'd like to introduce a case for the group to consider. And this is a 46-year-old man with a gastrointestinal stromal tumor with liver metastases, and this individual presents to your clinic. You can see on this CAT scan a heterogeneously enhancing liver metastasis on the right with the red arrow, and you can see the yellow arrow is pointing to a very large primary tumor that's occupying a lot of the stomach. You can see a little bit of air in contrast there to the left of the arrow. And this is a baseline scan that you see when the patient is presenting to your clinic. So now we have a question about this 46-year-old man with gastric GIST, translocated GIST with liver metastases, and the NGS revealed NTRK translocation. What is the next best step in management? So you did biopsy, you did NGS, you know there's an NTRK translocation, and what is the next step? A, initiate therapy with doxorubicin plus ifosfamide. B, order next generation sequencing. C, initiate therapy with imatinib. D, observe as GIST sometimes spontaneously regresses. Or E, initiate therapy with a TRK inhibitor. So the majority, 58%, say initiate therapy with a TRK inhibitor. And ding, 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 that's the right answer. Good job, everybody. In this case, we already had NTRK sequencing. Imatinib would not be the appropriate therapy for a TRK translocated GIST, just as a RAF mutant GIST should be treated with a RAF inhibitor. And GISTs don't really spontaneously regress, although sometimes they're misdiagnosed as a desmoid tumor, and sometimes they actually can occur with the desmoid tumor at the same time in the so-called Dumont syndrome. And desmoid tumors can spontaneously regress. So, but GIST does not. So the correct answer is initiate therapy with a TRK inhibitor. And I'd also like to say about that case, the patient is, we discussed with the surgeons, and as you would surmise, this is really not an operable patient at this time. However, with induction therapy with the TRK inhibitor, the patient may be able to have resection one day. We would certainly reevaluate that as time goes on. Okay, so here is the 46-year-old man with the NTRK translocated GIST. And the baseline you can see on the left with the red arrows. After 6 months of therapy, you can see not only are the tumors smaller, but now they're homogeneous. They're not taking up the IV contrast. They're darker, and what we would consider a very robust modified RECIST or CHOI response in this situation. And then after 12 months, the patient is actually doing even better. This is a really good response in a patient who was very close to hospice at the time of diagnosis. Okay, so NTRK fusion is a fusion that's observed in fibrosarcoma and GIST. Identification by NGS is really critical for optimal patient management in the diagnosis of fibrosarcoma, myxofibrosarcoma, UPS, and specifically GIST. And as we know from the data that was presented by Dr. Long, and I'm sure Dr. Leish will go over it, that NTRK inhibitors are safe and effective for patients with advanced or metastatic GIST as well as fibrosarcomas. So thank you. I appreciate your time and attention to this rare subset of a rare subset of cancer. And it's with pleasure that I turn the podium back over to Dr. Leish.
Perfect. Thank you very much, Dr. Trent, and thank you, Dr. Long, for your presentations. I'm going to talk about the pediatric and adolescent experience, but before I start, we'll again have a patient video.
So at 4 months, he presented with an enlarged head. The best way I could describe it is that he looked like a beluga whale at 4 months old. And so we went to a routine check-in with his pediatrician, and she had really found that the head growth was off the charts. So immediately they sent us for imaging, and we had an ultrasound, I believe it was 2 days later, and then the next day we were in pre-op and getting all of his operations in. So it was very quick. There was no time to think. It was more of reacting at that point and just following the guidance of the doctors and just hoping for the best. And so we sent the tumor for biomarker testing. About 3 weeks after the surgery, the results came back. And as soon as the doctors mentioned that we had to see a specialist, we knew when it was hematology and had to deal with neuro-oncology that this was pretty serious and the results weren't going to be in our favor. They explained to us the severity of what he had, the high-grade astrocytoma, and they explained to us our options, and they gave us the choice of either do nothing, chemotherapy, or the NTRK inhibitor medication. And so we went with the last option because we thought he was too small for chemotherapy. We also went to a separate hospital for a second opinion, and that was just heartbreaking because it was a full-on cancer hospital. And they had children there as small as Leon was, and they had adults, and it looked like those commercials, you know, that ask for donations that are cancer-specific hospitals. And it just broke our hearts. It really did, to have to think about our child in that category.
I mean, he was in the NICU after he was born for 2 months, and then we were in the hospital after surgery for like 2 weeks, and then we just were so done with hospitals, and we really couldn't muster like the mental energy to like go through chemo or radiation or like daily trips to the hospital. That just was not in our possibility of something that we could handle. So when they give us the option to NTRK and we can do it at home, and the only con they said was that we don't have long-term like a track record on it. But you know, they said there really had been no complications, so we kind of jumped at that opportunity to take that.
I think with the biomarker testing and the way the doctor explained it, it really solidified our decision. Without that information, I don't think we would have made a medically informed choice, and more than likely he would have ended up having chemotherapy. Granted, he was so young and so small, and you think of chemotherapy with radiation and wearing a port, but had we not had that information, I think the decision for his treatment plan wouldn't have gone NTRK inhibitor, for sure. So with treatment, they had explained to us it was the everyday oral medication. He would have to have imaging done by MRI every 3 months and have blood work every 3 months to make sure his liver function was compatible with or within range with working with the medication. So every time where he goes in for blood work, And images is where I'm on pins and needles again, of course. You want to know the medication is working well. So that's his general process and treatment. So it works well for us. And it blows my mind continuously that there is life-saving medication in my refrigerator next to the sour cream. Like, it really is incredible how far we've come with science.
Again, a very powerful video. A couple of polling questions before I start. The first is, in pediatric oncology, how would you rate your confidence in identifying which patients should be prioritized for NTRK fusion testing? Are you highly confident, moderately confident, somewhat confident, or not confident at all? Right. It looks like most people are not very confident, so hopefully we can address some of those questions today as we go through our talk. And the second question is, what is your biggest challenge when managing pediatric patients with NTRK fusion positive cancers? Adjusting doses for rapid growth and formulation availability, monitoring and managing unique pediatric toxicities, acquiring adequate tissue and securing timely genomic testing in infants and children, managing acquired resistance and sequencing targeted therapies, or not applicable because you don't treat pediatric patients. Right. It looks like, not unexpectedly, the majority of our audience are likely providers who treat adult patients, and that similarly to what we saw from the initial questions in adult patients, that the next most common challenge is getting tissue to test patients, and I think that's certainly true. Here's what I'm going to talk about in the next few minutes, and again, if you haven't already, please submit any questions you have online. We'll try to save a few minutes for questions at the end. So I'm excited as a pediatric oncologist to be able to show you a waterfall plot that actually has more patients on it than many of the adult waterfall plots that you just saw. That's very uncommon. But this is a waterfall plot highlighting the activity of larotrectinib in children with extracranial solid tumors, in which 99 patients were enrolled across the trial. This is a young group of patients. So NTRK fusions happen in patients of all ages, but are enriched for the youngest patients. So the median age is 2. And as you heard with adult patients, the majority of patients have NTRK1 or NTRK3 fusions, with NTRK2 fusions less common except in gliomas. Most of the patients on this study had infantile fibrosarcoma or soft tissue sarcomas, although there were a few patients with the other tumors that also have NTRK fusions. And what you can see is that the response rate was quite high, 86% objective response rate. And I think what's most exciting for me is that just over half of patients had a complete response to therapy, either a pathologic complete response, meaning that their tumor was resected and there was no viable tumor at the time of surgery, or radiographic complete response to treatment. So really remarkable activity for a single targeted agent in sarcoma. Larotrectinib has also been studied in children with primary CNS tumors, as you just heard from that powerful patient video. Here again, we see activity of this agent in patients with brain tumors, the objective response rate being 67% in those patients who have measurable disease at baseline. And this occurs across patients with both high-grade gliomas, as you just heard, as well as low-grade gliomas and other primary CNS tumors. The adverse effects of larotrectinib in children are quite similar to those in adults. It's generally quite well tolerated, with about 1/3 of patients in this study having a grade 3 or higher treatment-related adverse event of grade 3 or higher. The most common that we see in children are neutropenia and elevations in liver function tests. Generally, these are low grade and resolve on their own, although some require a dose interruption or dose reduction. We generally have not seen cumulative toxicities other than weight gain, which we see in children as well as adults. And they're not generally immunosuppressive in the way that we think about in pediatric oncology. So I give my patients their immunizations while they're on this therapy and don't give PJP prophylaxis. We see something similar with entrectinib. So here is a waterfall plot again of entrectinib in children with NTRK fusion positive solid tumors, here combining both primary CNS and extracranial solid tumors. And again, you see a very high response rate, north of 80%, and nearly half of patients experiencing a complete response to therapy, with responses in both patients with primary CNS tumors as well as extracranial solid tumors. Entrectinib is also well tolerated. Here you can see the adverse events that we're seeing. The things that are slightly more unique are elevation in creatinine, which is thought to be an inhibition of creatinine transporter by the drug rather than true impairment in renal function, as well as fractures that occurred in 27 of 91 patients on this trial, but generally also well tolerated in our patients. Given the sort of remarkable activity we've seen with these TRK inhibitors in patients with recurrent and refractory tumors, there's now been efforts to study these in frontline therapy for children. So the first effort was by Dr. Orbach and his colleagues in Europe, where they compared patients treated with infantile fibrosarcoma with chemotherapy to those treated on the larotrectinib trial and looked at the time to treatment failure. And on this Kaplan-Meier curve, the blue curve is the chemotherapy curve and the red curve is larotrectinib. And you can see that there was prolonged time to treatment failure when patients were treated with larotrectinib as their frontline therapy versus chemotherapy. And there were fewer patients that required a different systemic therapy, fewer patients that required radiation, fewer patients that required mutilating surgery, and fewer patients that died with frontline larotrectinib treatment. Given those results, we conducted the ADVL 1823 study through the Children's Oncology Group. This systematically evaluated using larotrectinib as frontline therapy for children with any NTRK fusion positive solid tumor. Patients were enrolled to two cohorts. Cohort A were patients with infantile fibrosarcoma, and cohort B were patients with other solid tumors, including some patients with primary CNS tumors. And again, you can see this waterfall plot where there was a strong activity of this agent with 100% response rate in those patients with infantile fibrosarcoma and a very high response rate in those patients with other soft tissue sarcoma solid tumors as well. You can see the event-free survival curve and the Kaplan-Meier curve on the top, and the overall survival curve is really remarkable, with more than 90% of these patients being alive at the end of the Kaplan-Meier curve. So as we think about using these drugs in children, formulation is something that we think a lot more about in the pediatric space than you do in the adult space. As you can imagine from that patient video, giving that little boy a pill would be very challenging or actually likely impossible. And so entrectinib is available in oral pellets that can be mixed in some food and given to patients that way. And larotrectinib is available as an oral solution that can be given orally or through an NG tube or G tube if necessary. Repotrectinib is currently available as capsules, and as I mentioned, is being studied in pediatric patients, but currently approved for patients 12 and older. So one of the questions we think probably more about in the pediatric space is, how long do I need to treat patients? You can imagine that giving a 60 or 70-year-old with lung cancer a lifelong therapy is different than giving that to someone who is 2 years of age. And so we and parents often ask, can we stop this treatment? And the SCOUT trial, the larotrectinib clinical trial, allowed patients to both have local control with surgery after we assessed response, as well as to enter a wait and see period where we tried discontinuing the drug to see if patients could maintain their remission off therapy. On SCOUT, a total of 47 of 91 patients entered the wait and see, and of those who entered the wait and see period, 66% remained progression-free as of this analysis. The periods of wait and see you can see are shown on this swimmer's plot in pink, so you can see that some of these patients have been off the drug for now many years without recurrence, and about a third of patients on this study had a recurrence when treatment was discontinued. We've looked at if there are predictors of which patients may be able to maintain their remission when therapy is discontinued. And not surprisingly, for these children with sarcoma, local control remains important. So those patients who are able to undergo surgical local control of their tumor are shown on this curve in the lower line, and the patients who did not have local control are shown in the upper line. So about 20% of patients had a recurrence if they had local control, and about 50% of patients had recurrence if they did not. We didn't see as much association with the radiographic response before treatment. It was more really surgical local control that dictated which patients may be more likely to recur. On ADVL1823, the Children's Oncology Group study, we had systematically assigned duration of therapy to test whether or not we could evaluate a defined treatment duration and evaluate outcomes. So patients who had a complete response were treated with larotrectinib for 12 cycles or about a year of therapy, and then therapy was withdrawn and they were observed. Patients who had a partial response could undergo surgery. If they could get a surgical complete resection of a localized tumor, they were again observed off therapy. And those patients who did not undergo a surgical resection to negative margins were observed on larotrectinib for 2 years, and then treatment was discontinued. And again, in this Kaplan-Meier curve on the right, you can see the outcomes for these patients. So the patients who had surgical resection are shown in the top in red. More than 90% of those patients maintained a durable remission when therapy was withdrawn, versus about 60% of patients who did not have surgery had their tumor recur. So how do I use this data in my practice? I think one of the most important things for me is that when we retreat patients who progress during this wait and see period, we can see patients respond again. So on both SCOUT and ADVL 1823, the majority of patients who progressed were retreated, and those patients who were retreated, the majority of them re-responded to therapy. And there were actually no patients who had progressive disease as their best response to retreatment. So when we stop, we see that many patients can be recaptured with retreatment with the same agent. And so from my takeaway and how I approach this with patients is that we think surgical local control is important. And if a patient has a localized tumor, I recommend local control if it can be done in a non-morbid fashion or a limited morbidity fashion. But if that cannot be done, I think it is worth considering offering a treatment holiday, because about half of patients may be able to maintain their response off treatment, and the majority of those who progress will be able to be retreated and recaptured, thus potentially sparing patients the need for lifelong therapy. We think about late effects of TRK inhibitors in children. There are known syndromes associated with congenital defects in these genes, genetic loss of these genes that include insensitivity to pain and anhidrosis, morbid obesity, and neurodevelopmental delays. These seem to be primarily effects that occur during in utero development when these proteins are important for neuronal development. But we are still studying the outcomes of children treated with these agents in the long term through a number of trials that are listed here to try to really understand if there are any other late effects of these therapies over time. I'll say that these trials have not yet read out their endpoints, but in my anecdotal experience and what we've seen so far, we haven't seen significant neurodevelopmental issues in patients. You heard about weight gain. This is another example that we do see some of these developmental toxicities in children. This is a growth chart of one of my patients who was treated with an NTRK inhibitor. And you can see there was quite rapid weight gain when the drug was initiated, to the point actually that we had to take this patient off the drug for a period of time due to the weight gain. We can also see patients that have withdrawal pain. This is thought due to tonic inhibition of TRK, that when you stop the TRK inhibitor, the nerves are more sensitive and you get this hyperesthesia or withdrawal pain. And so in some patients, we will wean the drug off over time to limit those toxicities. I'll also say that in children, we don't see as many neurologic toxicities as are reported in adults with these drugs. Some of that is probably because our patients are too little to report neurologic toxicities. But I think even in teenagers where we do see, where they could report them, we see less of that. And that may be that these toxicities are more common in older patients who may have other risk factors for neurologic events. So in the last few minutes, I'll go through this case study. So this is a 7-month-old patient who had a soft tissue sarcoma that presented as a forearm mass that was identified at birth. It was initially thought to be a hemangioma as a hypervascular lesion, and so was observed, but with continued growth, it was biopsied. And at the time of biopsy, we saw this hypercellular tumor composed of these fascicles of monomorphic spindle cells. And it was thought to be unresectable without amputation due to involvement of the radial and ulnar neurovascular bundles of the hand. So if you saw this patient, what molecular testing would you perform? Would you do FISH for ETV6, a DNA-based NGS assay, an RNA-based NGS assay, or pan-Trk immunohistochemistry? Right, it looks like most people would do RNA-based NGS. Dr. Cipriani is our pathologist. What would your opinion be?
Honestly,
with the morphology of an unknown spindle cell neoplasm, I'd probably go for both DNA and RNA because one doesn't necessarily know whether this is a fusion-associated or a mutated tumor. So I think the DNA would catch the mutations and the RNA would catch the fusions.
Perfect. That makes a lot of sense. And I think the ETV6, for those who don't know, again, ETV6, NTRK3, the most common NTRK fusion, and especially in infantile fibrosarcoma, about 80% of these will have them. So I think depending on the urgency of getting the result, sometimes I will do one or more of these at the same time, especially in this case, it was not life-threatening, but we do see some of these that are in life-threatening locations where we need to get a result as soon as possible and may do all of them, actually.
Mm-hmm.
Okay, so this patient was found to have an infantile fibrosarcoma with an ETV6 and TRK3 fusion and was treated with a TRK inhibitor and had a partial response by RECIST. You can see the response here on these MRIs, a very nice response with this sort of wisp of tumor, but unfortunately still encasing the neurovascular bundle as we so often see. And so the question is, how long would you continue treatment in this patient? 6 months, 12 months, 24 months, or indefinitely? Okay, again, we have a nice range. I think a few people would treat for 6 months, which I would agree with. I think that would be shorter, certainly, than has been studied in these patients without surgical resection of their tumor. Some would do 12, some would do 24, and some would do indefinitely. And I think this is one of those areas where there is no right answer. I don't know, Dr. Trent, if you have an opinion from a sarcoma standpoint.
You know, we tend to, in like, for instance, the case I showed, widely metastatic, we with aggressive tumor, we tend to treat indefinitely. But, you know, I think maybe the developmental issues and the side effects are different between the two populations.
And I think it's very well tolerated. These medicines are very well tolerated in pediatric patients. We just don't know the long-term side effects of growing up from the age of 7 months to 80 years old on a TRK inhibitor. So in this case, what we did was we treated for a year and then in shared decision-making with the family, made the decision to try discontinuing the therapy. Unfortunately, within 1 month, we saw progression of the tumor locally. And so the next question is, how would you treat this recurrence? Would you restart the same TRK inhibitor, switch to a second-generation TRK inhibitor, start cytotoxic chemotherapy, or amputate the arm? Right, it looks like most people would switch to a second-generation TRK inhibitor, which I think is very reasonable. As I mentioned, we do see patients respond to the same first-generation TRK inhibitor as well when they have progression off of treatment, which is very different than progression on treatment, which is almost always associated with either an on-target or off-target resistance mutation. Do you have any other comments about how you would treat this patient? Dr. Long or Dr. Trent?
I think for me, I would probably reuse the same TRK inhibitor first because of the fact that, you know, we do see when you retreat, they do high chance of response. And I think it's also to do with the fact that the patient has been able to tolerate that particular TRK inhibitor well previously. And in terms of the side effect profile, it's also easier for the patient to understand that they're getting on the same TRK inhibitor, also probably easier for the parents to also understand. So I would probably choose the first option.
Yeah, same.
Yeah.
Well, great. That is, in fact, what we did. And so in this patient, we retreated with the same TRK inhibitor and treated the patient for another year. At that time, the patient's parents, again, wanted to try discontinuing therapy, as we know that sometimes infantile fibrosarcoma is a disease that can, quote unquote, burn out over time. Unfortunately, again, we saw recurrence of the tumor within a month after therapy was discontinued. And so the patient was restarted again on the same TRK inhibitor for a third time. And then the family chose to undergo surgical resection, including resection of one of the nerves of the arm, about 6 weeks after retreatment to try to permanently remove the tumor. Interestingly, at that time, despite these multiple recurrences, there was no viable tumor seen pathologically, and the patient has now remained disease-free for more than 5 years off of all therapy. So we're able to spare the arm with mostly normal function of the hand, in this case, from a tumor that was otherwise unresectable. And I think we're almost out of time. So I want to thank Dr. Cipriani, Dr. Long, and Dr. Trent again for joining me. And thank you in the audience, both online and in the room. We really appreciate your attendance. And thank you.